Today we will be discussing the immune complex mediated small vessel vasculitis. I will be starting this, however, with a discussion of leukocytoclastic vasculitis, as this can be related to several of these or finding of several of these, including some of the other vasculitis conditions that we have discussed already. In the Chapel Hill nomenclature, however, it is discussed as a single organ vasculitis. Of the small vessel immune complex mediated vasculitis conditions, we will talk about IgA vasculitis or Henoch Schonlein Purpura. We'll talk about Cryoglobulinemia and Urticarial Vasculitis. As always, I encourage you to review the discussion of vasculitis introduction as a prerequisite for this. There are advertisements attached to my lectures now. These are done without my consent or knowledge. I don't necessarily endorse the products which are being advertised, and I'm not reimbursed for those. Let's dive into leukocytoclastic vasculitis and the immune complex mediated small vessel vasculitis. Again, as a quick review, if you have not had the opportunity to review the introduction to vasculitis discussion, vasculitis is an inflammation of the blood vessel wall. This can lead to necrosis of the blood vessel with either extravasation and perforation or obstruction of the blood vessel leading to peripheral infarction of the tissues. And it can be very dangerous. It can lead to either organ-ending or life-ending disease. Just a quick review of the Chapel Hill nomenclature. We've talked about large vessel vasculitis, medium vessel vasculitis, and ANCA-associated small vessel vasculitis. We'll now talk about the immune complex small vessel vasculitis. From our chart, I'm going to actually start with cutaneous leukocytoclastic vasculitis or angeitis, which is classified as single organ vasculitis, and then sashay into the immune complex vasculitis. And this is because many of these present with a leukocytoclastic angeitis picture. And so I wanted to talk about that first. So basically, leukocytoclastic vasculitis or cutaneous leukocytoclastic vasculitis is a small vessel vasculitis involving the capillaries and venules. And the hallmark is palpable purpura, which is shown in this picture. It looks like bleeding under the skin, but it's actually, one can feel it. It's palpable. And indeed, we've seen this already. The problem is this can exist as an isolated skin disease, which we're considering right now, or it can be a presentation of many other vasculitis conditions. And we've already seen evidence of that when we talked about granulomatosis with polyangiitis and when we discuss polyarteritis nodosum. So I want to go through the differential diagnosis of what can present as a cutaneous leukocytoclastic vasculitis. I am again copying my lecture notes, so you'll have this written down for you. You don't have to copy this. The things we're going to discuss today include the immune complex small vessel vasculitis, including IgA vasculitis and cryoglobulinemic vasculitis. We've already talked about ANCA-associated vasculitis, and we have seen pictures of this condition. This can be associated with lupus. This can be associated with the medium vessel vasculitis, polyarteritis nodosum. Sometimes it can occur with infections such as hepatitis C or immune complexes such as drug-induced immune complex disease. You can see a similar picture with infective endocarditis. Sometimes you can see a picture similar with lymphoproliferative malignancies. And there's other conditions which look similar. These are hematologic conditions, thrombocytopenic purpura, benign pigmented purpura, and then Schomburg disease. So it's sort of a vast differential, but that's why I wanted to consider it before we marched into the top two. Now this is a biopsy specimen of a patient with leukocytoclastic vasculitis. This, of course, is the blood vessel lumen, and what you see, at least early on, there's swelling of the vessel wall, which we're sort of past that in this picture. There can be transmural infiltration of the wall and around the wall with polymorphal nucleocytes, and you really don't see any. There may be a few in here, but it's hard to see. One can have fibrinoid necrosis, and in this picture, one can already sort of see that around the edge. There's sort of fibrosis around the edge of the tissue. There can be extravasation of the red cells outside of the blood vessel, and there's damage to endothelium. Again, clinically, what one sees when encounters this is palpable purpura. You can feel these things, and indeed, sometimes there can even be infarction of the tissue, and that's what you see here, infarction and tissue necrosis. Again, this is just another example of palpable purpura. Many of these pictures you've seen already during the vasculitis talks and the lupus talks. With respect to workup of this, skin biopsy is probably the most helpful, but also done with direct immunofluorescence in order to make the diagnosis. But then once one determines that there is a leukocytoclastic vasculitis, at that time one needs to go hunting to see if that's associated with anything. Therefore, you query about medicines to see if there's any clues that there might be a serum sickness. In other words, if they've been on a medicine, the serum sickness can be associated. Other organs are evaluated in order to determine if it is a systemic disease or just isolated to the skin. And in particular, I listed the lung and kidney, but as one thinks through many of the other vasculitis conditions we've seen, many other organs are involved than the lung and kidney. In investigating this, one needs to get blood counts and chemistries. The blood counts can lead to clues to platelet abnormalities or numbers which can look similar to a leukocytoclastic vasculitis. Serum complements are important. Consumption of complements can be associated with vasculitis, and we will discuss specific small vessel vasculitis associated with hypocomplementemia. Again, looking at the ANCA in order to determine if there's ANCA-associated vasculitis or the ANA to see if there's any clues of systemic lupus. Cryoglobulins are checked. Again, there is a immune complex small vessel vasculitis associated with cryoglobulins. Immune complexes are checked for. Hepatitis C and hepatitis B and HIV, as this can be associated with vasculitis. Blood cultures for clues for infection, echocardiogram, and blood cultures for clues for endocarditis, and of course, immunoglobulins. With respect to treatment, if a causative medicine is found, stop the medicine. If another vasculitis condition is identified, treat as per that condition. Otherwise, sometimes this can be treated with no medicines, with just leg elevation rest, compression stockings, possibly antihistamines. I will state in my practice, I didn't encounter these, but usually they were referred to me when they were refractory to other things. As with all the vasculitis conditions, corticosteroids are used and immunosuppressive drugs, including methotrexate, azathioprine, mycophenolate. Dapsone, which is we've not really talked about, can be used in this condition, cyclophosphamide, and IVIG. So we just discussed cutaneous leukocytoclastic vasculitis. I now want to sashay over to the immune complex vasculitis or vasculitis. Let's talk about IgA-associated vasculitis first, and we'll then touch on cryoglobulinemic vasculitis, hypocomplementemic urticarial vasculitis, and anti-glomerular basement membrane disease. Just as a review, this is a schematic of an antibody. Basically, we think two main parts of the antibody. The constant region, and this region down here is the same for each class of antibody, and this region down here is what affects the immune response, either fixing complement or whatever. This is the variable region of the antibody, and this is the part of the antibody that attaches to foreign protein. Now, there's several different antibody classes. IgG, which is the most common, and this is gives the long-lasting or immune memory. This can occur in the blood, cerebrospinal fluid, peritoneal fluid, etc. The IgM is the first immunoglobulins which is produced an immune response, and it's pentavalent. In other words, the schematic we saw, the previous picture was just one valent. The IgM actually has 5 of those attached to each other. IgA is found in external excretions, and such as saliva, the mucus, sweat, etc. And this is an immune response to local infections. It does have antiviral activity. And then the IgE has a high affinity for mast cells and basophils. These are the ones that can contain histamine, and this can cause a histamine release and an allergic reaction. Now, these antibodies can form complexes with the antigen that they're recognizing, especially if there's an antibody antigen equivalence. And what happens, instead of just floating around and carrying off the antigen, these all sort of complex together in these large insoluble immune complexes. A common target that would cause this is a drug, and that's what it's mentioned here. And that's why drugs can sometimes be associated with a serum sickness, which is where there's these immune complexes which can be trapped in the vessels, obstruct the vessels, and cause an immune reaction. The immune complexes don't always have to target medications as the antigen. Other antigens can cause this also, and including self-antigens, in other words, proteins from one's own body. So the first type of immune complex vasculitis that I would like to discuss is IgA vasculitis or Henoch Schonlein purpura. And this is immune-mediated vasculitis associated with IgA deposition. It's primarily a disease of childhood. So we've discussed one other disease of childhood, which was Kawasaki's disease. Henoch Schonlein purpura, or HSP, is another one. And this typically or most frequently occurs in children between the ages of 3 and 15. And what they do is they present with palpable purpura, but they're not thrombocytopenic and they don't have a coagulopathy. They can have an arthritis associated. There can be abdominal pain, and they can have renal disease. And what one sees with the renal disease is most frequently hematuria. They may have a little proteinuria, but not a lot of proteinuria, although sometimes this can march to nephrotic range proteinuria. This is just an example of the palpable purpura that can occur with it. Again, a leukocytoclastic vasculitis picture. And this is an example of the mesangial proliferation in a kidney of a patient with Henoch Schonlein purpura. If one does immunofluorescence studies, one will see that there's deposition of IgA in the kidney. Likewise, if one does immunofluorescence studies of skin tissue, one can see IgA complexes there also. So pathological findings is a leukocytoclastic vasculitis accompanied by IgA immune complexes. The serum IgA is elevated in about 50 to 70% of the patients. So we talked about getting immunoglobulins assays as part of our lab workup, and this is why, to look for this. The urinalysis frequently can show red cells, sometimes white cells, and cellular casts. Most often there's not a lot of proteinuria, but there can be, and if there is, we address it. This is the most recent classification criteria, and this is from EULAR. The ACR is not listed as a sponsor of this criteria. In order to classify this, the patient needs to have purpura petechia of the lower extremity with at least one of the 4 following criteria. So we're looking for palpable purpura, then we're looking for presence of abdominal pain, or a typical histopathology, which includes leukocytoclastic vasculitis with an IgA deposition, or a kidney with similar an IgA deposition, arthritis or arthralgias, and then kidney involvement. And that's greater than 0.3 grams of protein in 24 hours, or hematuria. That would help us to classify the condition. With respect to treatment, one doesn't always need to treat the kidneys. And so at least initially, one monitors the urine protein, looking for evidence of excess protein excretion, and typically what I follow is a protein creatinine ratio and a serum creatinine. If the creatinine is rising, or if the protein creatinine ratio suggests sufficient proteinuria, then a biopsy is considered. Treatment includes hydration and pain relief for the arthritis, either acetaminophen or nonsteroidal anti-inflammatory drug. If that progresses to the point that they cannot ambulate, then corticosteroids are initiated. Likewise, if the abdominal pain is so severe that they cannot eat, IV pulse corticosteroids are given. If the patient begins excretion of greater than 1 gram per day of protein or the creatinine is rising, then the kidney will be biopsied. And if there is felt to be a significant glomerulonephritis, IV pulse corticosteroids are used, or if not adequate, then mycophenolate or rituximab or cyclosporin or IVIG, plus or minus plasmapheresis. And if the kidneys involved, one may need antihypertensive therapy. We'll next consider cryoglobulinemic vasculitis, the immune complex small vessel vasculitis conditions. So basically what cryoglobulins is the precipitation of blood proteins at temperatures less than body temperature, 37 degrees Celsius. And cryoglobulins can precipitate from either serum or plasma, whereas cryofibrinogen precipitates from plasma only. How these form is one has the immunoglobulins. These can form complexes with antigen, and again, these will drop out of solubility in the blood as the temperature is dropped. There's several classes, and when cryoglobulins are detected, they should be analyzed. There's type 1 cryoglobulinemia. This typically involves a monoclonal protein such as Waldenstrom's macroglobulinuria or multiple myeloma. So this can generally is due to a hematologic malignancy or a blood cancer. Type 2 cryoglobulinemia is usually a mixture of a monoclonal IgM with a polyclonal IgG, and this can cause disease by either occluding the blood vessel or fixing complement and initiating an immune response. And then type 3 cryoglobulinemia is polyclonal. This is more often associated with connective tissue disease and again can either occlude a vessel or fix complement. Type 2 is more often associated with hepatitis C. So this is just another slide going through type 1 monoclonal IgM, about 10% of the cryoglobulins associated with hematologic malignancy, and again tends to cause disease by occluding blood vessels. Type 2 is a mixed cryoglobulin consisting of a monoclonal immunoglobulin complex with a polyclonal IgG, most typically associated with hepatitis C, and again can either fix complement or occlude the vessel. And type 3 is most often connected with other autoimmune diseases, and it's a polyclonal IgG or IgA with an IgM. Now, what does this do? What is the pathogenesis? Sometimes there can be central nervous system manifestations. This more often associated with hyperviscosity, such as occurs with a type 1, and they can get blurring of vision, trouble with vision, deafness, trouble thinking, confusion, vertigo, etc. Another manifestation is the skin. They can have palpable purpura with ulceration, necrosis, but one may also say things like Raynaud's, levator reticularis, and acrocyanosis, which is sort of a blueness of the distal fingers. This is just an example of cryoglobulins. That's a palpable purpura. This is just a kidney, and I think there might be some mesangial proliferation. There's not a lot of changes, and this is just a perivascular infiltrate associated with that. And this is a levator reticularis that can sometimes occur. Pulmonary disease, they can sometimes get small airway disease and neuropathy. There is a high percentage of neuropathy in mixed. Now, how one collects the cryoglobulins is important. Indeed, you need to quiz your lab as to how they do it. The blood needs to be collected and then immediately placed in a water bath at 37 degrees Celsius. In other words, they can't go up to the ward, collect the blood, just put it on their cart and take it down later. They have to immediately put it in a water bath at 37 degrees. The blood is then coagulated at 37 degrees, and then the serum is taken off and refrigerated at 4 degrees Celsius, and that time cryoglobulins are looked for. Once cryoglobulins are found, it is important to do immunophenotyping of them. So this is just an algorithm of how to treat these, but just a couple of notes. If it's a type 1 cryoglobulinemia, basically one needs to find the underlying hematologic disorder and treat that. If it's a type 2 or a type 3, if it's a type 2 and there's underlying hepatitis C, that should be treated. If it's type 3, we treat it like the other vasculitis conditions with corticosteroids, etc. Usually patients are treated in type 3 with corticosteroids with rituximab or cyclophosphamide. Next, consider hypocomplementemic urticarial vasculitis. This is a very rare vasculitis that clinically presents with urticaria or hives, but when one does a biopsy of the lesion, they're consistent with a leukocytoclastic vasculitis of the small vessels. The urticarial symptoms can be very painful in up to a third of the patients, and they are long-lasting. Each lesion can persist to up to 72 hours, whereas most usual urticaria or hives will persist for less than 24 hours. This is an example of the urticaria. It looks like hives. Now, in this condition, other organ systems can be involved. So they can have an associated arthritis again. There can be glomerulonephritis. There can be lung involvement with either COPD or asthma, but they can also have a hemoptysis or pleuritis or tracheal stenosis. They can have GI involvement with pain and hepatosplenomegaly. The eye can be involved with episcleritis or uveitis or conjunctivitis, and they can have neurologic involvement, such as pseudotumor cerebrae, which looks like cerebral hypertension or aseptic meningitis or cranial nerve palsies. And this can even include a transverse myelitis, which can cause paraplegia. The labs with this, again, the acute phase reactants, such as the sed rate and the C-reactive protein, are elevated. Given the name, you would expect hypocomplementemia. Indeed, that's what you have. There is evidence of immune complexes. There's a frequent association with an anti-nuclear antibody, and many of these patients actually do meet the classification criteria for systemic lupus. The biopsy, as one would expect, shows leukocytoclastic vasculitis, and again, immunofluorescence studies show deposition of immunoglobulins. One also sees swelling of the endothelial cells, red cell extravasation, fragmentation of the leukocytes, and fibrin in and around the vessels. The treatment of this, antihistamines are generally tried first, but that's typically not enough. Again, antihistamines because it looks like urticaria. Nonsteroidals are used for the arthritis and the pain. Glucocorticoids are used. Dapsone, we talked about dapsone when we mentioned Cryoglobulinemic vasculitis. It's also used in this. Colchicine has been used. Hydroxychloroquine, such as we would use in systemic lupus. For patients with refractory disease, then some of the immunosuppressive drugs, mycophenolate, methotrexate, azathioprine, or cyclosporin, or even targeted immunotherapy such as rituximab, anakinra, etc. Lastly, I'd like to mention anti-glomerular basement membrane disease or Goodpasture disease. And this is just a nod to this. Basically, this is a very rare condition associated with very rapidly progressive crescentic glomerulonephritis and then alveolar hemorrhage or bleeding from the lungs. And indeed, it can be very scary, and if not treated, can lead to death in up to 90% of the time. What one finds is that there's circulating antibodies to the glomerular basement membrane, and this then can lead to the glomerulonephritis and the bleeding, the lung bleeding. Treatment is primarily plasmapheresis with corticosteroids and cyclophosphamide. Thank you for coming today to listen to my talk about small vessel vasculitis, immune complex mediated. The next discussion will be on central nervous system angiitis.